Hello everyone and welcome to the third in this series of HIV Scotland Live Q&A events. We're delighted to be joining you this evening with two leading clinicians in HIV and sexual health across Scotland. I'm delighted to be able to introduce Dr. Daniela Brawley and Dr. Dan Clutterbuck, who's still working away in his clinic, but is joining us briefly this evening. So thanks for everyone that is watching the live stream, that's watching it back on our YouTube channel, and for submitting all of your questions. But I just wanted to start to basically, one is an introductory question, really, get you both to introduce yourself and sort of talk about your local and more national roles as well. So maybe we could start with you, Daniela.
Yeah, so I'm Daniela Brawley. I'm a consultant in sexual health and HIV. I'm lead for the service in NHS Grampian, which covers quite a large geographical area for both sexual health and for also HIV. And I also chair the National Sexual Health Leads, which is more around more sexual health issues.
Great, thanks. Dan, you're joining us from your clinic right now. Can you sort of give us a bit of an introduction?
I'm also a sexual health and HIV consultant. I'm lead for the Sexual and Reproductive Health Service in Lothian, based at Chalmers, and I am chair of the National HIV Clinical Leads for Scotland.
Now, one of the things that might be quite useful to explain is what those groups do, because I think sometimes we talk about them a lot, given that we go to the meetings, but in terms of what the function of those clinical leads groups are, what do you think are the main sort of activities that come from them that might be benefiting the people that are watching this evening? So
will I go first, Dan? From a sexual health leads point of view, it's all the lead clinicians for Scotland. So all the clinicians that lead the individual services in each health board area will meet usually on a quarterly basis, but that has ramped up massively during the last couple of weeks and months to try and support different areas of service development and delivery. But what our usual role is to try and make sure that we can provide high quality and equal quality sexual health services across Scotland. Make sure that we're doing it with the best evidence base. We're addressing inequalities in healthcare as well and delivery. So that is basically making sure that if you're that person, that individual accessing a service, that regardless of where you access it in Scotland, it should be the same quality.
Dan, did you have anything perhaps to add in terms of the HIV?
Well, just to say that maybe one of the strengths of NHS sexual health and HIV services in Scotland is that obviously Scotland's a small country. We have various government strategies and directives that tell us about what services we should be delivering, but within health boards, we tend to be a fairly small part of the service, and that's understandable. So what these groups, I think, allow us to do is get together as clinicians, but also we've got very strong links, not only to people like you, Nathan, and organisations like HIV Scotland, but Health Protection Scotland, Information Statistics Division, and government representatives, often quite senior people. And that lets us have both a direct link to government and also to drive things forward ourselves, because obviously we don't want to sit around and wait for central people to tell us to do things. And there's all sorts of things that we managed to drive forward as getting together as clinicians and saying, look, this is a really good way to improve services, or this is a problem, and let's get on and tackle it. And one of the most obvious examples in HIV is just being able to get together and discuss what the appropriate prescribing for HIV medication would be. And that meant that, we could, not only could we make sure that there was equity across Scotland and that we were all making sure that everybody was getting the access to the optimal treatment, but it's also meant that we could negotiate as a block which was a fantastic deal for Scotland. And we've made some phenomenal savings while still managing to get everybody every choice of treatment, which is, it's fantastic that through the NHS in Scotland, there is nothing really that we can't provide, which is enormous relief to clinicians and patients.
And one of the services that, I think is both of you I know worked on, and something that was done rapidly. So I guess these clinical groups were helpful in that, bringing people together, was the rapid introduction of PrEP just 2 years ago. Well, 3 years ago now, nearly 3 years ago. So was it that national groupings that helped really with the rapid scale up of services like PrEP that are new and innovative as well?
Daniela, you go.
Yeah, I certainly think so. I think everybody, when PrEP first came on the scene, and certainly patients were accessing it themselves, individual clinicians were working out ways to deal with that, both just in a case-by-case basis, but how we can make that more, again, equitable, making sure that everybody has access to it, because we realised very quickly this was a game changer in terms of HIV prevention. So those formal networks that we have, sexual health leads and the HIV leads that we've just alluded to, were absolutely vital in taking that forward, making sure that we were all on the same page and that we could push things forward in the right way. And I think the Scottish Government obviously were incredibly helpful with trying to push that through.
So we've been asking people across the last couple of weeks for some questions. So I'm going to go through some of these now. Will has sent in a message saying that he knows how supportive both of you are at ensuring that service users are involved in decision making and planning of services. Do you have any suggestions, ideas, or comments for local patient forums across Scotland on how to improve the message and recruit new advocates or activists? Dan, you can go first this time.
Okay. I think it's the thing that comes up repeatedly, and it's something I've been harping on not only today, but particularly in the last few weeks, which is clearly when change is going on, and my goodness, we've never had a rate of change as we've had in the last 6 weeks. Communication is just everything, and it sounds like it sounds a bit almost a bit pat, but it is really important. And I think the enthusiasm of the people involved, that I've come across in terms of patient forums is fantastic, but it's still an issue of awareness and recruitment. So I think really using every medium, from the most old-fashioned, like flyers, to using video screens in clinics, but also as much as possible trying to use Twitter and other social media, just to try and make it as inclusive as possible. And I know that the patient forums try very hard, but I think that's the thing, and just reminding clinicians to introduce and encourage people to the idea, because of course there's a certain amount of stigma still out there, particularly amongst some subgroups, but also, like anything, there's a reluctance to try something new. There's a little bit of apprehension, often amongst people who've got a really useful different perspective to contribute.
Yeah, I completely agree. I think as well, it's making sure that, I suppose, patients realise what they can get out of it. So it's not just that pure support, but it's actually shaping services. And often, the patients that we have in I'll have to plug our local peer support group, OPVG, which are fantastic. They've been at the forefront of trying to change how we run services and making sure that it's definitely patient focused. So maybe that's our fault as clinicians and service leads, that we have to maybe promote that a bit more and say there's lots of positive aspects to be involved in peer support and patient involvement.
And I think things are going to look different going forward, and maybe now is an opportunity. I mean, we know things, whatever the new normal is, it isn't going to be what we had before. So this is a new opportunity to ask people, and we're already discussing ways in which to do that by through questionnaires and so on. But obviously, strengthening patient forums is going to be an important part of that, and this is an opportunity to refresh it and rethink it.
Yeah, so wherever you're watching from, go to your local service, get involved. We need you.
So one of the questions we had actually, Daniela, was around our Positive Voice Grampian. So it's good that you give them a shout out. But it was more from someone looking to learn from them, I think, in terms of what. So the question is, what do you think have been the greatest challenges for you and them in improving partnerships across Grampian? Because they do seem to be one of the most vocal, engaged patient forums across Scotland that have got some considerable wins under their belt in terms of getting things changed for patients, as you've said. So what have potentially been the challenges, either for you and as a health board clinical lead, but also for them in trying to break down those barriers?
Yeah, I think setting up a patient forum is always difficult, especially if you're starting from scratch, and certainly that's where we were a couple of years ago. But we have just had fantastic members of the team involved. So I'm very much in the background with this. This is the OPVG that have taken this forward. And I think that's key, having people that are really engaged and, as I said before, that see the benefit in being involved in it, that they can directly impact how services are delivered. But as you say, it can still be difficult, and it's also, we're now several years down the line, and it's taken time. So it's making sure that people also, have that tenacity to keep going, and that's what we have had locally, which has been fantastic. And I think everyone, despite the kind of pressures of trying to get more people involved, or maybe having a wider group that completely represents the cohort, we just really value the fact that we have this group that just does so much in Grampian. In terms of challenges, I think things have been. I think the way we work together has been so cohesive that actually a lot of the challenges that we might traditionally have came across, we've tried our best both from the health board side to try and make that as easy as possible, but also we've had such engagement from the peer support group that, from my perspective anyway, I think we've generally had pretty good outcomes. So I think that's been the mainstay. Obviously easy to say out loud, but maybe harder to actually put into practice.
And Dan, one of the questions for you specifically was around the question very specifically from Will is, if you could wave a magic wand, how would you improve services in the Lothians for people living with HIV?
I would have a single service structure, which we've already committed to do, but I would move forward making that happen. I would decentralize that structure so that there were more points of access, so that it was easier for people to access things more local to them. And obviously parts of that would be about the things we're starting to do, which is more remote working and telemedicine, but recognizing that doesn't work for everybody, and face-to-face consultations are so phenomenally valuable. And I would strengthen the links with GPs and hospitals, but particularly with GPs, so that we were just getting more seamless care, particularly for those people with other issues, and for the 40% of our cohort are over 60, and the increasing numbers that will move into that group where they might have other health needs. And we do okay from that point of view, but we don't do half as well as we could be doing in terms of people knowing who to go for what, but also being able to go to their GP, and their GP to know exactly what's going on with their HIV care, and to be able to have a consultation with their HIV carer at the same time.
Thanks for that. Now we've got a question from Ian on YouTube, who's asked if PrEP is still available in the northeast of Scotland or the Highlands. And I wondered, Daniela, if you wanted to answer
Yeah,
that.
that's no problem. So yeah, we still have PrEP available. Obviously, our face-to-face clinical provision has rapidly reduced because of all the restrictions that everyone obviously understands. So we're delivering that via a phone consultation, video consultation, and assessing whether people do need to come in for face-to-face bloods. So yes, it is still available in Grampian. I'm not sure off the top of my head about Highland. I believe they do have some service capacity, but they may need to connect directly with that service.
Okay, thank you very much. Now, the next question we've got from Ian is around the sort of impact on coronavirus services and CD4 counts. So Ian said that his next consultation appointment that was scheduled for June was cancelled today, as there are no routine appointments being carried out. My last CD4 test was done in August 2019, as this is now only being done once a year, and he's concerned that by the time of the next test, he'll not have had his CD4 checked for 18 months. In light of COVID-19, is it not more important that we have up-to-date CD4 levels so we know where we stand regarding vulnerability to COVID-19? Who wants to take that one first?
Well, I'll take that.
Yep.
I didn't actually catch where it was, but I probably doesn't make much difference. So I would say, what I would say to people I'm looking after is, certainly if your last CD4 count was over 350, I would not be at all concerned. There's a lot of discussion internationally about whether it's even necessary to do CD4 counts once it's over 350, and there's a very strong argument for just stopping altogether. Now, I think it's very true that certainly my generation of clinicians and lots of patients are very attached to CD4 count and find it very reassuring. But if we were being evidence-based and rational, we would just stop. If the CD4 count's less than that, and particularly if it's been significantly lower in the recent past, or then there might be an argument to say you would want to do it more than every 18 months. And if it was under 200, then and that's been advised, it might be worth a discussion with the clinic if you're particularly anxious. But I would say if it was over 350 at the last occasion, it really doesn't matter. What matters is the viral load, and as long as your viral load was undetectable last time and you've been taking your medication reliably, you've really not got anything to be concerned about. The second part of it is around COVID, and it's everything suggests that for those people with a CD4 count over 350 and undetectable viral load, then the risk of COVID is either the same as anybody who's HIV negative, or if there is any increase, it is incredibly marginal. We've not picked it up yet. And as you know, there have been a frightening number of COVID cases, and we would know by now. I think it's also reasonable to assume that even people sit with a CD4 count lower than 350 and undetectable viral load, their COVID risk, notwithstanding any other problems they've got, is either not raised or marginally raised. And the only people we're really concerned about is people who've had a serious, what we call an opportunistic infection in the last 6 months, or whose CD4 count is under 50 and they fall into the shielding category. I want to add to that and have more to say.
No, I think I completely agree. You know, we've CD4 counts we've kind of stopped doing actually. Somebody's CD4 counts over 350, unless there was a raised viral load or another issue. And I appreciate people's concerns around that though at this time. You know, I understand why people are worried about their immunity when we're talking about shielding patients for lots of different reasons. So I probably encourage people, if they are worried about that, to phone your HIV service and have a with them at least, and then you get a bit of reassurance around that. But yeah, 100% what Dan says, yeah.
It's maybe that although obviously services doors are closed, access is different. All services in Scotland are providing services. It may be online to book a phone back. It may be direct phone. But I would be very surprised if any service showed any irritation or concern. If you're worried about something like that and you're under care for HIV, I don't think there's any service that couldn't afford the minutes required to talk you through it and make sure that you were reassured or that you came up with a plan that would make you feel okay about it. I don't think that would be a problem to any service.
And I guess a lot of what's been happening is blanket cancellations of appointments, reshifting appointments to meet the new service requirements. And like you say, Dan, if someone was concerned about something and that phone call or that ability to talk to the clinic, I'm sure there could be some willingness to either have that conversation or get in an appointment if there is an issue with something.
And I think it's also that, maybe 6 weeks ago or 7 weeks ago, there was a bit of, not panic, but obviously services had to change really, really quickly. So there would have been a blanket cancellation on lots of things. Services are now thinking very differently about how things are delivered. We're by no means out of the COVID pandemic, but, as Dan has said, the services are all there to deliver things in a different way. And whether that's a telephone consultation or in some areas, you can do a video consultation. Even if somebody does need bloods, there's ways to do it. So yeah, I think the bottom line is to contact your service if you're worried.
The next question we've got is about condoms. So the question is, condoms may not be readily available at the moment, and I certainly remember getting an email about a global condom shortage at the start of the pandemic. Is there then a drop in STIs due to COVID lockdown? And then the question goes on to say, are sexual health clinics offering testing for COVID to people who might be presenting with STIs during the pandemic? And what your thoughts might be on COVID-19 being visible in semen? So there's a few questions there. One about condom accessibility, and is that causing a drop in STIs, but could that also be related to testing? And if sexual health clinics are offering referral testing for COVID-19 to people that might have been presenting with STIs?
I can take the first one, certainly. So I think the STI rates are going to be really interesting to see because they're dependent on so many different factors. We know certainly because services had to shift and reduce their capacity quite quickly to completely understandably, obviously, support the response to COVID pandemic planning within the NHS, the testing capacity has dropped. So the less tests we do, the less infections we'll pick up. Certainly some of the anecdotal evidence so far suggests that people are adhering to lockdown, having less sex, having less non-regular partners, which would potentially say that there would be less likelihood or less chances of people having STI transmission. But until we're out the end of this, really, we won't know that for sure. So I think we're still quite in the middle of this just now. STIs may drop, but we cannot say that for sure just now. Certainly, I'm not aware of any local or national condom issues, and every health board is still providing free condoms, either by post or by phoning services. So again, if anyone's having issues with that, I would contact your local sexual health service, and they'll put you in touch with a way to be able to access condoms freely, and that should still be available.
Great, thanks. So we've got a couple of questions that come in. So I'm going to take they might be both for you to respond to, Daniela. Unfortunately, they're coming from people in the northeast. So Ian's asked that he attends near the clinic in Elgin about news on whether he could rebook his blood test that was cancelled due to COVID. I'm assuming, that's something as simple as phoning the clinic that you would attend, Daniela, but you'll have more knowledge than me.
Yeah, so basically we're assessing case-by-case basis on whether patients need bloods done just now. I think, we used to do viral loads every 3 months, and then we went to 6 months. So there's been a bit of an understanding in the HIV community that actually if we push people's bloods out by another month or two, that actually if that person has been undetectable for years with no issues with their medication, then delaying their bloods by a few months really shouldn't do them any harm. And actually we're balancing that with the harm that might be there if somebody accesses or comes into a healthcare facility because of the risk of COVID. So that's been done on a case-by-case basis. So I think the bottom line is to contact the services. So certainly I can talk for Grampian that we still have the availability to do blood tests in our Aberdeen site. And we also have some availability to do that within the Dr. Dre's site in Elgin. But we are doing that obviously on a case-by-case basis.
And the next one, you'll know this name, Daniela. Colin has commented on Facebook saying that our Positive Voice Grampian, who are the patient forum in the Northeast, are doing so well because of Danny and the team within NHS Grampian. One question, will you be able to start holding the HIV working group meetings by video conference? Yes,
and Colin can help set it up for me. She's much more into IT than I am.
Great. So we've got a couple more questions, and I'll just say if anyone's that's watching that's got any final questions, then do get them in. Martin's asked if someone with HIV is admitted to hospital with COVID-19, is placed on a ventilator and sedated, how is their HIV medication administered? I don't know if anyone's got any experience or
I don't have experience of it in relation to COVID, because I'm glad to say we've had very few COVID admissions, and we're pretty confident that about across Scotland. We've had very few COVID admissions in people with HIV, and they've tended to do very well. So I don't have numbers for how many people have been ventilated, but it is not many. In terms of prior experience, there are some antiretrovirals that can be administered by a tube in liquid form or a granular form through a nasogastric tube while someone was sedated. So in the past, where that's been required, it does almost always mean a change of medication, because most of the modern medications we've got that most people are taking that are so tolerable and effective are not routinely available. But with discussions between the ITU team and the HIV team, we can come up with something for the time that they were sedated.
Great. I guess we've been seeing very, in population terms, low numbers of people living with HIV, and that's what's I think led to a lot of the earlier conversations as well, continuing about whether HIV treatment has been a good option for either treating coronavirus or what's more. I think what more people are thinking is it working preventing it? And I know there's a study ongoing in Spain at the moment looking at Truvada as a prevention method as well, rather than treating it. But we were talking to Professor Sharon Lewin from Melbourne, who's been one of the world's most renowned HIV cure researchers, but whose all of her work is now coronavirus, and she's been taking all of the learning from that cure research into looking at a vaccine for coronavirus. Yeah, so that was a really interesting conversation. The final question that we've got so far, but I'm going to pose a final question afterwards, just based on what the title we called this video. But this next question is around the potential move or availability of intramuscular treatments, because the question says taking oral HIV medication can put some can in some people be very toxic to the liver, causing elevated enzymes or liver inflammation. When do we think intramuscular treatment could be made available in Scotland, and would it be made available to people where they may have some liver issues, so that it would bypass the liver to enable them to stop those I've lost my words. Stop the interactions between current medication and perhaps severe liver problems.
You want me to go for that?
Yeah, will you go back?
Okay. Every date at the moment has a caveat. I would have been optimistic based on what I was told that we might have some availability of cabotegravir by 2021. I still think that's not unreasonable, but the way things are, you know, everything's been delayed, and that includes things like licensing and you know, registration of drugs. A lot of those things will be on hold. But I think we could be reasonably optimistic about next year. In terms of the specific use, I think it's difficult to say that. I think it's very unlikely that you would have a blanket availability criteria that says if there was this problem. I think the same principles as we use for everything else would apply, which would be assuming it was licensed and we decided it had a place in Scotland, which if there's good evidence that would be very likely but not guaranteed, then it would be exactly the same as other medication in that we would follow our outline guidance, which is cost sensitive. So where there are a number of options, we will go for the cheaper option. But if there are limited options for a patient, there's been nothing that's been licensed and approved that we've had a blanket ban on in Scotland. So there will be a place for it. And the obvious things would be where people are intolerant of all the other drugs or are unable to take oral medication or unable to take it reliably. And then we would be considering injectables as an option. So I think maybe sticking my neck out a little bit, but I think it's very likely, given what's happened in the past, that it would be available to those people who needed it and didn't have other obvious options. Daniela,
did you have anything to add there?
Yes, I agree with Dan. It's really difficult to know when things are going to happen, just because, you know, particularly when it's a process that needs agreement, like we do in Scotland for drug approval. A lot of that work might be shifted to more COVID-based, or there'll be a backlog of things that have been put on hold because people have been redeployed. So timelines just now are really difficult. I think one of the things I was just kind of thinking around is that, particularly from a contraceptive point of view, we've been stopping things that are patient facing just now, so injections, implants, coils. So while COVID is going on, you know, it's just thinking about that kind of patient interaction. So that might be something just to consider if, and hopefully it doesn't happen, hopefully COVID is over sooner rather than later, but that might just be something to consider in terms of whether people want to switch to something that's injectable rather than oral. But there is definitely a role for patients who are either intolerant or have interaction issues or swallowing difficulties, absorption issues, or as well as adherence issues as well.
Great. Well, that was all the questions that were submitted. The question I wanted to pose to both of you, because we titled this this video HIV PrEP and Getting to Zero. So it would really be that's the sort of the thing that I'm most interested in is, what does getting to zero mean to you, and how do we get there? And will we start with Dan again to give Dan, because you've just finished answering, Daniela.
Easy question, Dan.
Well, as you know, Nathan, there's a lot of discussion about what it means. There's a certain amount of consensus, but not complete. I think I think as a relatively short-term aim, as in 3 to 5 years, I think we should be talking about 0 preventable HIV transmissions in Scotland, so that we shouldn't have any case where somebody, for example, who's at risk of sexual transmission and had been to a clinic or had any interaction with a service acquired HIV in Scotland. And as a longer term aim, I'd say 2030, which obviously is a date we've used in terms of internationally and fast track cities and UN8. I think it would be fair to say 0 transmissions in Scotland, so that we aimed that everybody who needed a prevention intervention was able to access it, that we had enough testing that everybody was diagnosed quickly, and that everybody who was diagnosed was on treatment rapidly enough to stop onward transmission. And that's really quite an ambitious task, but I think there's a lot of us, including I know you and HIV Scotland, who are game on to face that challenge.
And what do you think, is there one thing that you think we're perhaps not doing at the moment that would help us get there? Or is that a combination of lots of things?
It's testing. Yeah. I mean, there's some new challenges, as you know, because we've concentrated very much on sexual transmission in Scotland, and we've made some progress. We've got some new challenges around people who inject drugs, and that links into all sorts of things around accessibility and inclusivity and taking services out, and possibly, actually, as Daniela was alluding to injectables, to using injectables for treatment, but also around PrEP, which is and again, potential possibilities around injectables for PrEP. But then there's the whole issue of we're getting PrEP as tablets to a massive population of largely gay identified MSM. But we're still with barriers, with significant barriers around vulnerabilities, particularly where there's a combination of vulnerabilities, and particularly where people have social vulnerabilities tied in with geographic vulnerabilities. So people who are in rural areas and maybe have other things going on, would be those mental health issues, be those just simply be financial issues, maybe disclosure, maybe identity issues, and we're just not accessing those people, and we're really not getting PrEP to anybody, significant numbers of people who aren't cis male MSM. So some of them.
Daniela.
Just to add, I mean, I completely 100% agree with what Dan's saying in terms of the aims. I think one of the big issues is to try and really address stigma, because I think that will help us increase testing. It will help us increase engagement in services, so we don't have those patients who are lost to follow-up, who often are lost to follow-up because of stigma. So we will, reduce our transmissions, reduce our HIV-related deaths. It's all extremely intertwined in terms of achieving these outcomes. I think the stigma issue is the big one that is, one of the hardest nuts to crack. We can think of lots of innovative ways to test. As you'll probably allude to, you've got your online HIV testing starting through HIV Scotland. There might be other pilots and things happening in other areas as time goes on. We can do outreach services and try and engage those other groups of patients that maybe don't access traditional services. And I think personally that's where we really need to go. But all of that isn't going to work in the long term unless we really address stigma and have a really honest conversation around what that means to the public, what that means to people, and try and get that message out there. And I think we're all trying our best to do that, but how do we do that better?
I think those were great answers, and there's certainly there's lots more to do. and lots more to get on with, which I think has been what's keeping me sane during the lockdown and working from home. But that's all we've got time for this evening's. But thank you both, Daniela and Dan, for joining us for this Q&A. Next week we've got Bruce Richmond and Mercy Shabemba, who are two global HIV activists that are taking that fight forward about trying to reach all of those marginalised groups and people that services might find hard to reach, but we've not been necessarily the best at reaching them. So we'll be having that discussion next week. And in the meantime, if anyone's watching that needs any information about HIV PrEP or COVID-19, then do please head over to www.hiv.scot/coronavirus. And I'll see you next week. Goodbye.
Thank you for the invitation.
Thank you.